Thank you very much, Dr. Nakira. In relation to your reference to couples, I'm going to here make a public confession. My first conversation with Paulina, I approached her and I said, I am interested in dating you, but before that I would like to know whether you would be willing to write in the area of personality disorder significant contributions, because I want to make sure that our interests are coincident or complementary. She said, dear Otto, I'll be glad to answer your question, but before that I would like to ask you, are you willing to work in the area of personality disorder and write significant things so I can pursue my professional interests without being hindered by a husband who is not, I'm sorry, Otto, I mean by a boyfriend who is not interested in the same things as I. In this rational way, started a passionate relationship. Now, more seriously, I'm very grateful for the introduction. There's one book I want to mention, of which I'm not the first author, but which I think is really very important, and I dare to say that precisely because I'm not the only author. The authors are Clarkin, Yeomans, and myself. John Clarkin, Frank Yeomans, and myself, and it's called Psychotherapy with Borderline Patients. I mentioned it yesterday, but I assume that many of you were not there yesterday. And it is a book about psychoanalytic psychotherapy for severe personality disorders. It is written in a relatively simple way, but not simplistic, not superficial. You know, this is your couch, this is your napkin, and it is the first effort to manualize a long-term psychoanalytic psychotherapy. It has empirical backing, it has research, it can be taught, it can be evaluated objectively through videotapes, its effectiveness has been studied, empirical, we are doing research. So I believe it's a major breakthrough, although many psychoanalysts get horrified because true psychoanalysts only do psychoanalysis and nothing else. And so I warmly recommend it to you, especially as I'm going to refer to it as one of the treatment modalities for the patients about whom I'm going to talk today. I'll try to, the subject is the almost untreatable narcissistic patients. And this comes from the experience of our Institute for Personality Disorders. We have just completed an empirical research comparing 3 groups of 30 patients each, treated 1 year respectively with dialectic behavior therapy of Marshall Linehan, our psychoanalytic psychotherapy, which we call TFP, transference-focused psychotherapy, and supportive psychotherapy based upon a psychoanalytic model, which are the 3 types of psychotherapy used for nowadays for treating patients with personality disorders, and also providing them with the medication using the Soul-Off model. So we have done all that can be done to study comparative effectiveness. We are in the process of evaluating all these data. I talked a little about this yesterday. I won't mention this further today, except to tell you that what I'm presenting is our experience based upon that population, and a summary of it. And of course, it's influenced by my general approach to the diagnosis and study of psychopathology of narcissistic patients. First of all, so you're getting a kind of a clinical rather than research findings, and I decided to talk freely, to condense a big chunk of material. I'm not presenting today PowerPoint. We have a professor of ethics at Cornell who starts out a conference saying, I know you are smart people, you don't need PowerPoint, so I'm going to smart people, you don't need PowerPoint. And I understand, I'll talk for about an hour, and I understand that then we have a discussion and we stop at 12. Is that a fair statement? Okay. Let me run you through all the aspects of pathological narcissism briefly. levels of personality disorders. 3 levels. First, those who are functioning extremely well. Nobody would think there's anything wrong with them. They seem a little grandiose, self-assured, full of themselves, but everything is fine, sociable, they have stable relationships. It's only in their intimate relations that one senses a kind of a vacuum, and they usually don't come for treatment, except if they have some other symptom, and so the personality is discovered, so to speak, as a byproduct. Then you have a second level, the typical narcissistic personality of the books, and I'm going to describe that in detail, where the pathological personality already creates significant problems, but they are functioning well socially. It is at work, in intimate relations where the problems pop up. These are usually candidates for psycholytic treatment, which is the ideal treatment for them. And then you have a third level, the most severe ones, who function what we call at an overtly borderline level, with ego weakness, lack of anxiety control, lack of anxiety tolerance, lack of impulse control, lack of sublimatory functioning, and they are very often mistaken for ordinary borderline patients. They get into the hospital as borderline patients, and we have to make the differential diagnosis between the usual borderline patient and narcissistic personalities functioning on a borderline level. Those have indication for TFP, transference-focused psychotherapy, but are contraindication for psychoanalysis. And within that group, there is a subgroup with severe antisocial behavior. These are the most severely ill personality disorders, and we'll expand on that because there we come to the limits of treatability and also to a very important differential diagnosis that runs from the borderline level to the antisocial personality proper. The antisocial personality proper is nothing but a severe, extremely severe personality disorder with complete deterioration or absence of superego functioning. These are not two separate personality disorders. And this audience, I don't need to say that the classification system in the DSM classification system is absurd. It's not absurd, but totally insufficient. I'm being kind to them, so we are talking at a different level of diagnostic assessment. Now, description of the typical narcissistic personality, the intermediate level. There are 3 major groups of symptoms. Abnormality of the self-concept with the dominance of grandiosity. Second, abnormality of relations with significant others with dominance of conscious and unconscious envy. And third, abnormality of value systems. They're being stuck on infantile value systems because of an insufficient development of mature superego functions. Main symptoms within the pathological self, self-centeredness, over-dependency on admiration, excessive development of fantasies of success and grandiosity, avoidance of realities that would shatter those fantasies, and bouts of insecurity that disrupt that sense of grandiosity. In the second area of relations with others, conscious and unconscious envy. The unconscious envy showing particularly in devaluation of that or those whom they envy. A sense of greediness and exploitiveness, incapacity to depend on others, because to depend is granting them a superiority. To depend means to be inferior for these patients. Defenses against dependency are enormous in these patients. Lack of empathy with others, shallowness of emotional relations, and lack of capacity to commitments, to ideas, work, ideals that go beyond gratification of grandiosity and their own needs. In the third area, there is a deficient capacity of the higher level superego functions, such as incapacity to mourn because of loss, a tendency to regulate their self-esteem, not normally by limited self-criticism, but in a primitive way by mood swings. So you have mood swings, severe mood swings, anything really goes wrong, instead of being, or they have to recognize something that they did was wrong, immediately depression, rather than a more restricted, concrete self-criticism. A tendency to have what sociologists call shame culture rather than guilt culture. They don't steal because it would be terrible if they were caught, not because of a sense of guilt. Their values remain at an infantile level. Somebody is valuable because he's nice, he's well dressed, has shining cars. I mean, it's not because of one's moral, intellectual, ethical, human values, but because of the kind of things that a child is proud of. And that shows very often in the childlike insistence on presence, on things, on external presentation. And of course, the form this takes depends on social and cultural background. Aristocratic person dresses very elegantly. If it's low middle class, what in low middle class seems to be comme il faut. And the most severe cases with more deterioration and absence of value systems that permit antisocial behavior, lying, stealing, manipulating false checks, irresponsibility with money, which is passive, exploitive behavior, antisocial behavior, or aggressive behavior, destruction of property, physical attack of others, to assault, robbery, murder. Finally, a paranoid orientation. What happens is that the pathological grandiose self that usually protects narcissistic personalities from their own aggression and permits an idealized self-representation to dominate is too weak to avoid the infiltration of the self with aggression, so that aggression against which the pathological grandiose self is directed erupts in consciousness, and that aggression becomes egosyntonic. So you have a pathological grandiose self that's an aggressive one, that indicates severe absence or limitation of superego functions as well as intense aggression. And part of it is projected, superego precursors are projected, and determines the paranoid orientation. So that what you have here is narcissistic personalities with antisocial behavior, strong paranoid features, and egosyntonic aggression. That determines the syndrome of malignant narcissism, intermediate between the narcissistic personality and the antisocial personality proper. And the next level is the antisocial personality proper, where you have chronic antisocial behavior of a passive or aggressive type, complete absence of the capacity of guilt or concern for self and others, incapacity for any relationship except an exploitive or parasitic one, incapacity to project oneself into the future, which in part is a superego function. So they are fantastic criminals in the short run and idiotic in terms of projecting the long-term consequences of their action. They lack what has been called the milk of human kindness, and those patients have prognosis 0. for any kind of psychotherapeutic treatment. And those of you who work in the forensic system may use this for the differential diagnosis of antisocial behavior, because in any patient with antisocial behavior, you have a set of differential diagnosis which goes from the most severe to the mildest and determines the prognosis. And unfortunately, forensic psychiatrists, to a large majority, ignore that, not to speak of judges, and not to speak of journalists, may they write in peace, who say nobody thought that this child who was so nice should then kill his comrades. You know, I mean, everyday press. So, what is the list? First, anybody with antisocial behavior, evaluate whether the person has an antisocial personality proper. Start with the worst first. If it's not, that's worst prognosis, antisocial personality proper. Second, syndrome of malignant narcissism. I just have described it. That's still treatable. That's a psycholytic psychotherapy, but not psychoanalysis. Third, narcissistic personalities with antisocial behavior. That's quite frequent and treatable, and doesn't contraindicate necessarily psychoanalysis. Depends on the case. Fourth, other severe personality disorders, not narcissistic, with antisocial behavior. That's already better. Next, patients with non-severe personality disorder, what we call neurotic personality organization rather than borderline personality organization. There the prognosis is very good with analysis. These are the criminals out of unconscious guilt described by Freud. That's the only group that Freud really described. And by the way, he said everything about narcissism except describing narcissistic personalities. You know, that is post-Freud, although the first one who had inkling of it was Abraham in his paper on a particular resistance against the psycholytic treatment. Next, antisocial behavior as an adjustment disorder in adolescence, good prognosis. Next, antisocial behavior as part of what the British authors call the dissocial syndrome, no adaptation to an antisocial social subgroup, a minority group that has antisocial behavior, adjustment to that, and antisocial behavior as part of the adjustment to an antisocial group. And finally, occasional antisocial behavior that has no particular relevance to psychopathology proper. If you keep that in mind, it gives you a tremendous instrument for diagnosing such patients. I forgot to say that when I talk about egosyntonic aggression, it's not only directed toward others, but it can be directed against self in the form of severe self-mutilation and suicide. And one has to differentiate the self-cutting borderline, the ordinary borderline patients who self-cut or become suicidal as part of temper tantrums in reaction to immediate frustration or other situations, from the narcissistic self-attack that happen cold as an assertion of superiority, a carefully prepared suicide over a period of time, or self-mutilation with a sense of triumph. Everybody is worried about pain, illness, death. I'm above that. If the world is not good enough, goodbye, dear world. So there is a kind of a more malignant type of suicide. Patients who come to sessions and tell they are fine to the therapist, and they burn themselves to the bone and have infected arms, all hidden behind flowered, nice dresses. I'm talking about those patients. So here we have not only the most severe narcissistic pathology, but a very important differential diagnosis of utmost importance for treatment. And finally, in all narcissistic personalities, there is a basic self-state, a sense of emptiness or boredom, needing external stimuli to be interested. In the milder cases, these are patients who look, for example, for a partner who animates them. A patient of mine says, oh, she didn't animate me. That's a typical narcissistic patient's statement. And that stimulus hunger, of course, predisposes them to addictions, alcohol abuse, various types of addictions. In the entire pathology, there are a number of complications that are very frequent. Sexual promiscuity because of unconscious envy and devaluation of the other sex. So they idealize, the woman idealizes a man, devalues him, takes on the next, devalues him, can't stick with anybody. In the most severe cases, they can't fall in love, and of course they can't love, and so it's a question we always have you ever fallen in love? Now, if you have a 15-year-old adolescent, he or she may not yet, but by the time somebody's 25 and says, have you fallen in love? I don't know. That's already a significant statement. Then there are some with severe sexual inhibition instead of promiscuity, afraid of being rejected or being considered as inferior. So it can go the other way. I mentioned already drug dependence or alcoholism as complications. And there is a narcissistic suicidality as an escape mechanism from anything in reality that's not gratifying the grandiosity. In a sense, I can always walk out. Usually that indicates, of course, extremely severe aggression directed against yourself and superego pathology in terms of incapacity to elaborate or deal or contain this aggression. These patients I already mentioned, the most severe ones mask all the symptoms of borderline patients, and usually you can differentiate them from the ordinary borderline patients who have a primitive, dependent, clinging quality, in that the narcissistic borderline patients don't have that. They tend to be aloof, distant, exploitive, but not really dependent. So immediately you can differentiate that in initial diagnostic interviews. Of course, one complication is a tendency towards social parasitism and exploitiveness. They feel very entitled. All of them feel entitled. And if they are in the borderline field and they have a compliant social system that declares them chronically ill, and psychiatrists declare them unfit for work, they suffer chronically from depression and anxiety, I can't work. So you get them on SSI, social support, housing, and they become masterful exploiters of the state. And let me say that the two prognostically most negative aspects for any kind of treatment are, first, antisocial behavior. The worse the antisocial behavior, worse the prognosis. And second, secondary gain. And when the secondary gain is too big, nothing you can do. Among us, as I mentioned yesterday, Michael Stone developed Michael Stone 1.5 formula, saying that if a patient by education, background, knowledge can earn 1.5 times what he's getting from Social Security or from the family, there's a chance. If not, no chance for treatment. Cynical, but unfortunately true. Okay. That's, in a nutshell, the descriptive pathology. Now, typical clinical presentations of these patients, because they come under different surface symptoms. First, chronic work failure in contrast to high capacities. Work failure that may have to do with their terrible relations with everybody else, the sense of resentment because they are not the CEO, they have to be CEO or nothing. And there are many patients who prefer to live on public assistance other than working in a subordinate position. And if they can be a CEO, that's all right. If not, they prefer to beg on the streets. Second presentation, antisocial behavior. They are sent by the judge or family, and there you have to establish the differential diagnosis that I mentioned to you before. Third, they may come because of suicidal behavior, severe suicidal behavior, and there you have to make the differentiation. Suicide as part of a severe depression or suicide without depression. one of the first things we tell our residents, there are patients who are suicidal without being depressed. For some reason in the culture, when you're suicidal, it means you're depressed. And it means if somebody says, I'm depressed, well, then he's depressed. Rather than us saying, what do you mean? There are many patients who learn to say, I'm depressed. It's an entrance ticket to many things, and you only discover they are not when you ask them, what do you mean by that, what it's all about. So with suicidality, you have to make the differential diagnosis: suicide because of severe depression, suicide without depression, and there differentiate suicide in ordinary borderline patient and the suicide in narcissistic personalities that indicates severe egosyntonic aggression, and immediately you raise the question, is that the syndrome of malignant narcissism? You immediately get a sense of severity. Frequently they present as chronic pathology of love relation. A woman has chronic relationship with two men and she doesn't know whom of the two to choose. A man has a string of sexual relations. He thinks life is great as long as he can jump from one woman to the next. Then all his friends are married, they have children. He can't stick with any woman more than a few months and he gets worried and comes to treatment. Then patients who come with chronic parasitism, chronic anxiety, chronic depression, they go from one psychiatrist, the psychiatrists get fed up, they go from one to the next. These are the ones with secondary gain. They just want the psychiatrist to confirm that they're ill, be kind of hurt, surrender friend, paid by the state, and get all the other support. Then patients come with alcoholism or drug dependency, and I've summarized frequent presentations for secondary symptoms behind which you find the personality. But of course, there are also patients who come directly say, I have problems. I have problems at work. I have problems at home. Something is wrong. And they want help. I mean, these are optimal situations coming out of an internal sense of concern and awakening awareness that there's some problem that needs treatment. Regarding overall prognosis, I already mentioned to you the bad prognostic implication of antisocial behavior, of secondary gain. I would add to this that the more severely affected are the object relations, the less the patient is able to have some relationship in which the patient hangs in with all his problems, the worse the prognosis. And then intelligence, in that the treatments geared to modify them in general require at least normal intelligence. So the patient who have an IQ below 90 or 85 limit the treatment to supportive treatments that are more limited than analytic treatment. Okay. Now, then there are some prognostic implications that show up only in the treatment, namely negative therapeutic reactions. And there are three types of negative therapeutic reactions I mentioned yesterday. First, the very mild ones that these patients don't have, which is negative therapeutic reaction out of unconscious guilt. Patient gets worse when he feels help because of severe superego features. Freud described that, the criminals out of unconscious guilt, and interpretive approach to that is very positive. That's not what I'm talking about. Second level, extremely frequent, is unconscious, is the negative therapeutic reaction out of unconscious envy of the therapist. Typical for narcissistic personalities in psychoanalysis or psychoanalytic psychotherapy, and that can be resolved by interpretation, but it has to be diagnosed as interpreted systematically, not once and for all. Third level, and that's the really severe one, those who have been severely battered or mistreated in the past and have a profound identification with the battering object and a sense that only somebody who kills them loves them. So the only persons who are interested are those who destroy them and provoke all the therapists to hate them and mistreat them. And these are fortunately few cases, but their prognosis is very negative. And sometimes you can diagnose this knowing that somebody has already been treated by several therapists, excellent therapists who seems they've done the best, and the patient would get typically worse with each of them. That may be a contraindication for an analytic approach, shifting into a purely supportive one and carefully manipulating lack of deepening in the transference situation. If patients come with drug dependency, alcohol dependency, that has to be treated first. So dependency first, detox, rehab, then treatment with treatment contract as for borderline patients. If it's abuse but not dependency, you may try to control that by contract at the beginning of the treatment. In any case, that may be the point at which, if this cannot be completely and safely and absolutely controlled, a psychoanalytic modality of treatment becomes impossible and you shift into a supportive modality. And of course, one basic question is, to what extent, with all the defenses against dependency, is the patient still able to tolerate a dependent relationship? And in part, sometimes you can only discover during the treatment situation. You can't tell ahead of time. And to this day, I wouldn't be able to predict it. I've had surprises in both directions. I'm seeing an adolescent where I thought the prognosis was very questionable, and he's doing extremely well. I saw a woman in our project where I was quite hopeful, and it was a disaster. I didn't get anywhere. Beautiful illustration of treatment failure. By the way, we have every session on videotape of every patient over a year, 2 sessions per week. I'm quite proud of that. And of course, it was possible thanks to the very generous help from a Swiss foundation that gave us a lot of money. Unfortunately, during a limited period of time. Greediness is not an exclusive property of narcissistic personality. There are some patients who really only tolerate getting medication because they have in their pocket. They're not depending on anybody. And of course, nowadays they find easily sellers of that merchandise. There are many patients who accept a supportive relationship because they see the therapist, somebody who teaches them skills, and then they learn them and they become their own therapist. So by extracting what is useful, and now they know it all, they don't need the therapist anymore, they can be helped. And I think that's the dynamic behind the helpfulness for some of these patients of the cognitive behavior therapy, such as DBT, dialectic behavior therapy. We are still evaluating. What we are doing now is to evaluate which patient improved with which treatment for what mechanism, and to have a more complex understanding of what is going on. There are some patients who really, where the superego features show in a total irresponsibility to other. They don't come to always come late, don't come to the session, are irresponsible for years with any kind of treatment, and are probably untreatable. And what we do with those patients is tell them, look, you have starved, you have interrupted, everything never come. I'm willing to treat you under these conditions. You stop coming, fine, we interrupt the treatment. I'll always be glad to refer you to somebody else, but this will not work. So a treatment contract is an extremely important aspect of this psychoanalytic psychotherapy with severely ill patients. And that's the advantage of that book that I recommended to you, because it describes that in detail. In fact, we have another text on contract setting in the treatment with borderline patients by Yeomans and 2 other members of our group. But perhaps that's too highly specialized at this point, except if you're interested in particular treatment of those patients. Psychodynamics, general psychodynamics of narcissistic patients in any psychoanalytic treatment or psychoanalytic psychotherapy. And of course, this shows most clearly in psychoanalytic treatment proper. First, the incapacity to depend. it shows in the patient trying to use the therapist as a kind of a vending machine of interpretation. The patient has to talk, but he has to hear something, the important thing, what he learns, and then he applies that and makes it his. So he learns from the therapist, and this permits him to maintain independence. Such a learning situation is still tolerable. And there is also very typically an omnipotent control, which shows in the sense that the therapist has to be as great as the patient. Because if the therapist is inferior, the patient is wasting his time, immediate evaluation. If the therapist is superior, the patient feels envious and can't tolerate it. So I had a patient analysis. Every time I made an interpretation, the patient would say, and I would have said, thanks. Carefully evaluating whether this interpretation was still good enough. And very frequently the analyst is treated as the greatest analyst, can be a first-year resident, doesn't matter. And the patient can therefore tolerate that. Or, so the analyst is the greatest, and the patient is with the greatest. That is, as long as he's with the greatest, it's okay, because then he's superior to all the other patients of all the other therapists. That's a solution. Or the patient is the greatest, and if the analyst is grateful that he has such a great patient, you know, you have a patient like me, then the treatment can be tolerated, because even if the patient is to learn from the analyst, at least he knows that he has the admiration. You know, if you treat me well, it will help you because I'll refer very important people to you. This kind of attitude. So this tends to subtly affect the therapist, who tries to be very careful. If he doesn't say the right thing, it will be devalued. So that combination, and the patient very often does self-analysis. There are patients who do free association analysis and ignore the analyst present. If the analyst says anything, they have a startled reaction. They forgot there was somebody else in the room. So which makes the treatment having a kind of a first session quality for many months, and is quite disconcerting. There may be competition with the therapist, of course, and at the same time suspiciousness of the indifference of the therapist, his exploitive quality, projecting on to the therapist the patient's own attitude, and also projecting the devaluation and contempt, as if the therapist would be contemptuous for any shortcoming or weakness of the patient. That all of this creates a lack of a real relationship, which may show up in the countertransference, provoking extreme boredom in the therapist because he's treated as a non-person. These patients put the therapist to sleep, and it is as if there were no real patient, no transference, and it is the systematic analysis of the defenses against dependency, because it means inferiority, dominates the early stages for many months of the treatment of these patients. Gradually, the envy of the therapist becomes quite dominant, and at the bottom, the envy of the creativity of the therapist that is denied. Patient may complain, there's nothing going on and you're not helping me, and then there comes a session in which the therapist helps the patient, everything's a breakthrough, fantastic session. Next session, the patient comes in, I don't know why I'm still coming here, there's nothing helping me. Of course, there are many acting out of this. In the worst cases, patients, one of the patients whom I had in treatment in the project, while she was seeing me, she bought tapes through a radio program, self-treatment for borderline patients, and I only learned weeks later that she was comparing the tapes with what I was doing. I couldn't compete with the tapes. And patients who, if they have an indication for medication, use that to say this is that patient was telling me, do I still have to come? I'm feeling much better with the medication that Dr. So-and-so is giving me. I know I'm doing this for you because you are doing research, but you see, I have to think of myself as well. My time is important. Gradually, the deep aggression connected with envy breaks through, and then there may be suicidal tendencies or parasuicidal behavior as a triumph over the therapist, development of strong paranoid tendencies. Everything looks worse, but in fact it's better because now there's an object relation going on of the pathological grandiose self is breaking up and the underlying primitive borderline conflicts are showing up. And by the way, the analysis of the pathological grandiose self really is an analysis of many features that come together in determining the patient's grandiosity, particularly the identification with grandiose aspects of his dominant objects of the past. And so that one really analyzes his identification with idealized grandiose objects, and it's like a gradual decomposition of the pathological grandiose self. Eventually direct sense of rage for being frustrated, for not being loved, for being entitled come out with narcissistic rage and demandingness, and of course at the same time the aggression may show in highly destructive ways, such as stealing, so to speak, interpretation. A patient applies, hears interpretation, they don't apply to him, but he uses it with others. And sometimes he uses what he gets from the therapist to attack others. He uses what he gets, so to speak, in love as an expression of aggression. And that's called perversity. It's not perversion. It's perverse transferences. The use of the relationship for destructive or self-destructive purposes. Very disturbing to therapists, but it can be analyzed as a way of resentful, destruction of what he gets out of unconscious envy. And of course the superego corruption may be acted out and in curious ways. Patient acts antisocially with an unconscious sense. It's all the responsibility of the therapist. And the therapist is caught between appearing like a sadistic superego or colluding with the patient. So technically this makes difficulties. A very frequent problem is the unconscious envy of the other sex, unconscious homosexual conflicts, and behind sexual promiscuity very often there is this unconscious envy. And if that because it's a fundamental source of limitations. Somebody who wants to be the greatest is limited by being of one's own gender, and that's unfair. We have to be of both genders at the same time. It's a very frequent fantasy and determination of certain primitive forms of homosexual conflicts. And gradually, as the patient gets better, tolerance of aggression increases, tolerance of envy without acting it out, the capacity to not destroy what he gets, and to developing a capacity for gratitude, guilt over their own aggression, and depressions may develop, a tolerance of superego functions. Some of these patients become severely suicidal, not of the kind that I mentioned before, but out of deep depression and guilt that needs to be analyzed in turn. In general, we can talk about, in some cases with antisocial behavior, a typical sequence of what we call psychopathic transferences, where the patient thinks the therapist is dishonest or he's dishonest, there's lack of honesty of communication, that evolves into paranoid transferences as the patient gets better, and finally into depressive transferences over a long period of time. And leads to the rule that you have to interpret, whenever there are a mixture of these, you have to interpret the psychopathic before the paranoid and the paranoid before the depressive defenses. And there is gradually a capacity for developing object relations in depth, and capacity for development of dependency, of concern, more realistic appraisal and in depth of others, of self, of the therapist, and tolerance of improvement. Very often the patient improves without telling the therapist, denies improve. The therapist hears from other people, oh, he's doing so much better. Not in the treatment, the therapist would never guess that. There are particular complications, the so-called syndrome of arrogance, described by Bion, patients who are extremely arrogant, who act as if they didn't understand anything cognitively, pseudo-stupidity, arrogance, and extreme curiosity about the therapist as a form of control. Curiosity, arrogance, pseudo-stupidity. That's very disturbing when you're not used to it, and very primitive patients, but understanding that these are defenses against acknowledgement of aggression. It's acted out rather than being experienced. And we have to learn that there are patients who attack you brutally without honestly being aware that they are attacking, because the behavior defends them against self-reflection about the affect involved. And sometimes the interpretation is, you're afraid of enjoying your attacks on me and can only do it blindly because you're afraid of it. It's this direction of the interpretation. Okay. I have not talked about alternative theories of narcissism. If you want to do that, it's fine. Clearly, there's a certain direction of analysis here, interpretation. It's different from the French approach of André Green and Kernberg. It's different from Kohutian approach, and it has similarities, although some differences with the Kleinian approach of Rosenfeld and Steiner. I'm prepared to discuss that with you if you are interested in. Now, last part of my presentation, typical cases of the most severe ones that we've seen. Sometimes with success, sometimes with failure. First, extremely severe suicidality as part of a syndrome of malignant narcissism. A patient who all the time was threatening with suicide and with an unconscious pleasure in keeping the therapist on tenterhooks, and the treatment was centered by constant trying to be aware what's the latest preparation. If the therapist didn't guess in time what the patient was doing, she was going to kill herself. Another patient we had who was taking rat poison is a chronic suicidal attempt. Rat poison contains anticoagulant, and she had severe internal hemorrhages, life-threatening ones. And she managed to get that into the hospital. And while she was being in psychotherapy, she continued. Her prothrombin time was getting more and more prolonged, while she was denying emphatically. And the searches, sometimes we found a little, then nothing. And the therapist was being exhausted by being faced with chronic lying that couldn't be overcome, and the patient's unconscious and conscious pleasure in being in control. Nobody could catch her. They would catch the people with razor blades or with glass who want to cut themselves, but that little powder could be hidden very easily, and that was a treatment that failed. We had in another city where we have a group replicating our findings, we had a tragic situation. One of the early patients, a therapist with strong narcissistic features, started a patient with syndrome of malignant narcissism who told her, I want to kill myself and nobody's going to stop me. And you won't either. And the therapist started the treatment anyhow without doing the contract that's indicated, namely reach an agreement that this is something that the patient is not going to do. Patient commits himself and that's it, so that you eliminate the threat by by contract setting. The patient was not willing to do that, and what we would do is therefore not treat the patient, refer the patient. When I say not treat, we never abandon the patient, always refer the patient to somebody else. Honestly, we tell the therapist we were not able to treat that patient. We don't tell the therapist, oh, I have a very interesting case for you, you know. So here, second type of impossible situation, almost untreatable. In all these, I'm not saying they are impossible. I'm just saying that we are at the limit and often need the experience to tell. I'm telling you where we are at the limit. Do you follow me? I'm not saying we have a solution to it. I'm just saying we are alert to it, we're working on it, and we believe that everybody has cases like this, and that it's important to study them, communicate in order to advance our knowledge and the possibility of helping patients. Supported social parasitism. I already mentioned to you the Michael Stone 1.5 formula. In the state of New York, it is terrible. There's a huge system there. There are case managers and all kind of thing, and we waste our money, while on the other hand there's insufficient money given for health, social intelligence. So that we get these patients who have such who are not going to improve because of secondary gain. But sometimes, of course, you also get it with patients who come from a different environment. We saw one patient, a male homosexual, a beautiful man. I mean, he looked like a Greek Apollo. And he was an expert in going to elegant bars in his city where he would seduce people whom he knew belonged to the business aristocracy and become the lover of an extremely wealthy businessman who would maintain him. So he was now this is how he made a living. A man with a college degree, extremely intelligent and educated, and a total passive exploitive relationship to life. And he came, and his lover was willing to pay for the entire treatment. Or say, I'll pay for the how many years of treatment? 5 years of treatment, I'll give you a check. So the patient came saying, I come here for treatment, and so-and-so is going to pay for the treatment. And so we decided with that secondary gain, so we said we are willing to treat him, but he will have to work, and if not, paying totally sufficiently for the treatment. The patient looked with an indignation as if we had told him to walk naked on Times Square. And, of course, he did not come to treatment. We saw whose father was paying for treatment. Told the therapist, I'm willing to enter treatment as long as my father pays, because I don't think that treatment is worth anything for me to pay. So if you're willing to take me, fine. Treatment started, trying to work this through in the treatment, but one day the patient said, now my father is not paying anymore, so I'm ending. Thank you very much. Please send the last bill to the father. And he left from one day to the next with a very good therapist. I mean, when I talk about incapacity to depend after a month of treatment, I mean it. I hope you see the tragedy behind this. Huh? Then you have cultural support of certain narcissistic defenses. A patient from a cultural minority that was supporting a kind of haughty, exploitive, exhibitionistic behavior and rewarding it in terms of money and jobs, and who enacted that with the therapist, depreciating the therapist as being conventional, square, middle class, establishment, the ruling culture, and this was and he had sufficient support from his social system to end the treatment. So you may find ideological support for this. A woman who is a feminist with a male therapist who says, look, I should be in treatment with a woman anyhow, and then the feminist ideology is used as a rationalization of narcissistic devaluation of the therapist. It goes both directions. Culture. Then you have splitting processes. Patients find another therapist who says, oh, this is no good treatment, and they use one therapist against the other and are able to use whatever controversies are in the field to undermine the treatment. Then there are patients whose, as I mentioned before, severe arrogance protects them against any treatment because they know it has failures, there's nothing demonstrated, who says demonstrate to me, and they undermine from psychoanalysts to psychopharmacologists, and at the same time with the sense that they are entitled, everybody should try to treat them. And though they collect a treatment system, everybody desperately trying to help them, and they act on the surface they want help, while underneath being the impossible patient who is superior and has the entire establishment concerned with them. And that many of these patients go from hospital to hospital and make a living out of becoming the impossible case, the difficult case, and they don't mind total failure in life as long as they are what in Spanish is called, in Chile, la guagua del bautismo, the baby of the baptism, everybody centering around them. Then there are patients who on the surface look fine, but there is a secondary defensive, very interesting, their repressive mechanism, massive repression of all the unconscious, the conflicts around envy. And these are patients where no deeper content emerges, who may fall asleep if they're in analysis on the couch and have an irresistible need to sleep and may sleep half an hour, and you wake them up and interpret, and finally the therapist has to struggle against letting them sleep in peace and sleeping himself. So it's just an emptiness, and a defensive emptiness that often can be resolved, but sometimes not. I had a patient who started the treatment with a dream, sitting in a house of stone like a Magritte painting, if you have seen that, a grey, everything is of stone, chairs, table, pictures, everything is grey, there's nothing. And he said he opened the door to that, and there was a field covered with grey stones, nothing. He was telling me this emptiness in one of the early sessions with a smile on his face. And I said, you're telling me about this terrible emptiness with a smile on your face. Anything comes to mind about this? He said, no, I'm just amused, because there was nothing there except grey things, and I was amused thinking what you would be able to make of that. So I said, it sounds as if it gave you a certain pleasure to think that I probably couldn't make anything. Here was this expert on dreams who would kind of sweat it out. And the patient laughed happily. You can see how much he expected help from me. And then, of course, the patient who used drugs or alcohol. It's perhaps obvious, but one patient of mine his wife was a very successful businesswoman. He was an unsuccessful businessman who, in not being able to compete with her, dropped his business altogether, began to drink. She was complaining about his drinking. He'd stopped doing everything. His problem was alcoholism. Came to the project, and in the treatment, it immediately tried to show his superiority. I mean, his life was a shambles, and he came as the great businessman. He intimidated everybody with his attitudes, and couldn't tolerate accepting the fact that he was failing in life, and he interrupted the treatment in order to avoid a consciousness of failure. He would say, yes, he had a problem with alcoholism, but he was not inferior as a businessman to his wife. I mean, madness. Number of cases like this of patients who, failing to be on top of their job, drop everything and prefer to be on the street. And some of this is so powerful that they cannot tolerate a treatment which, after all, will confront them with failure. Okay, to finish, let me just say regarding treatment. Non-overtly borderline, non-malignant narcissism analysis, even if there are antisocial features. Overtly borderline, severe antisocial features, TFP, transference-focused psychotherapy, or psychoanalytic psychotherapy, carefully evaluating individually contraindications. Patients in whom the antisocial elements are so strong that they interfere with verbal communication, chronic lying that cannot be overcome in the early analytic work, patients with enormous secondary gain, etc., it is preferable to shift in a supportive modality. In a supportive modality in which you feed into the narcissistic resistances by giving the patient advice, counsel, intervene in his life, and that permits to improve behavior pattern in the very severely ill patients. What it doesn't do is resolve the capacity for intimate commitments, sexual and love relations, and those patients you really, to change, they need to be treated. And particularly with severe sexual or love conflicts, say a patient who is between two women, doesn't know, has a relationship for years with the two women and doesn't know which way to go. You first try, and the patient who resists any treatment of his personality, you may first try to give a period of evaluation at a conscious level of conflicts, counseling, and see whether in that context he can reach a decision, or whether his equilibrium is so stable that nothing can be done at this point, or whether the patient, aware that he can't resolve it and wanting to do more after the contacts with you, then can enter into treatment. You see, that is a very complicated decision, but if it's done right, it can be very helpful. Sometimes, I'll give you one example. A businessman involved with two women, and both of them, I mean, very influential families, friends, social life, in the magazines and newspaper, known by everybody, the two families fighting with each other, the two women fighting with each other, and he came to treatment because he didn't know which way to go. It took a few sessions to see that he had a profound pleasure in having two family systems fighting over him and two very famous women trying to get him, and so I ended motivation for treatment 0, severe, well-organized narcissistic personality. A number of psychiatrists had failed to help him, and so I told him, you're a man who needs two women, it's clear. Try to maintain it. It's their problem. One of them may not tolerate the situation, and you may end up with one only. Then we have to see whether you suffer under that, need another one, or whether it solves your problem, and I'll be glad to help you at any point. But as long as they tolerate it, and you already have seen all these psychiatrists, I think you have to accept yourself as you are. And you are nice to them, you're friendly, you're very good to them. You have to teach them that they have part of your time. If they love you enough, they may accept that. If not, they are free agents. He almost embraced me. I want somebody who I'm sure is going to tell his friends if they need a psychiatrist to come to see me. Thank you very much. May I start with a comment? Several people have asked me again about our manual. The title of the book is Psychotherapy with Borderline Patients, and the authors are John Clarkin, Frank Yeomans, spelled W-E-O-M-A-N-S, and myself. And I believe now that it was published by Wiley and not Basic Books in 1998. I'm not totally certain.
Y, not W.
Oh, yeah, Y, yeah. Y. Did I say W? No, I'm sorry. Y, yes. Y, yes. Thank you. And it's not written as it's written as a text, and but it's really our manual. And by the way, it has Dr. Yeomans has written what is called a primer of TFP, of transfer and psychotherapy for beginning therapists, which is a simplified version of the same value. So you can recommend that to beginning therapists. It's very well written, it's very clear, it doesn't have the complexity and sophistication of the one that I mentioned to you.
Questions?
There's one more thing I want to add, if I may. I shouldn't be more, but one prognostic indicator, once the patient is in treatment, of patients with intense negative transference, I mean who bombard you aggressively, is there's a difference between those who use threat of ending the treatment as their aggression, from those who are enraged with you because you're not doing what they want to do. In other words, they're not threatening you with ending the treatment. They just want you to be different or recognize something and that they are right. Do you see that difference? Because using the threat of end of treatment as a sense of superiority really shows that the incapacity to depend, while rageful dependency is already a significant advancement. For example, one of our patients developed a psychotic transference and thought that she was being persecuted by one of our secretaries, and she wanted me to punish the secretary. And I mean, it was sheer madness. And she was for weeks. She was enraged, threatened me with going to take legal action and all the rest. But there was a tremendous dependency, in contrast to the patients who simply stay away or use a kind of grandiose devaluation of the treatment. I'm talking patient after months of treatment. In general, we found in our research that the dropout rate, this is a preliminary finding, I'm not yet certain whether this will hold up, but it fits with expectations at least. The dropout rate, the early dropout rate, is probably higher for this treatment than for cognitive behavior therapies and supportive psychotherapy, because we are making demands on the patients. So more drop out, and we can't drop out because we don't treat them, or they drop out, whichever. But after 6 months of treatment, very few of our patients drop out anymore. Once the analytic approach hooks them into treatment, it's very solid, although these are such severely ill patients. So while I've stressed the limitations, I also want to stress the power of the treatment to deal with such patients. I just wanted to add that.
Dr. Kernberg, you mentioned a patient who is continually late or doesn't come, doesn't show.
Yes.
What is underneath that?
Well, it is obvious.
Dependence?
Well, first of all, devaluation of the therapist. Patient gets late or doesn't show because doesn't give any importance to the therapist and makes it very clear. So you have to analyze that systematically, what it means, and how you have to analyze the fact that the patient is devaluating, and why does he have to devaluate? What are the risks of taking the therapist seriously? That varies from case to case. So you analyze you point out the devaluation, the contempt. You are not saying you are contemptuous, but there's some part of you that is contemptuous. We analyze the component object. There's something in you, one part of you, that is very contemptuous and depreciatory. You don't say that, but your actions speak then, and perhaps you are afraid to recognizing how much you depreciate me. You're afraid of that and have to act on it rather than saying it. And that in turn may protect you against something much more dangerous, to feeling that you really need me, that you really have serious problems, that your life is limited and so on. Because to acknowledge that honestly would make you feel very bad about yourself. And you're trying to protect a view, you're okay, it's the others who are failing you. If the world were just doing what it should, you'd be all right. I mean, that might be an illustration. I'm condensing. And you have to do that systematically. That is a high priority, as long as it's not resolved. I don't mean that's the only thing you're going to discuss with the patient, but it's dominant on your mind and whenever it fits in the sessions. We have priorities for interpretation. In the manual, all this is very clearly explained. What certain priorities are that override other tactical decisions, what and how to interpret. Our approach is really a strict application of psychoanalytic technique, combining both an ego-psychological approach, Otto Kernberg's book on technique, which is kind of one basis, and a Kleinian approach to the analysis of primitive defense mechanisms. That's a very powerful combination. And that's, I think, the dominant one in modern psychoanalytic trends internationally, in my view. I mean, there are alternative psychoanalytic technical approaches, but I think that's the most important one at this time, and rightly so, I think. Yes?
When you mentioned that when a patient gets to a point where they begin to lose the grandiosity of the defense, they may develop the underlying depressive reaction.
Yes.
Do you frequently then begin a medication to assist? Or
No. Very good question. Usually you can deal with this analytically, except if there is such a severe depression, really severe depression, that it either interferes with the patient's work or coming to sessions, or acquires conditions of being the symptoms of a major depression, where a patient develops a major depression, and I make that diagnosis very strictly, then there's indication for medication. As long it's a characterological, it has characteristic of dysthymic reaction, and as long as there is no real serious acute suicidal danger derived from depression. Suicide as a symptom of depression is different from characterological suicide. Characterological suicide has to be interpreted, not treated with antidepressants. So these are the limits. So we evaluate that very carefully. Yes?
I'm curious about common developmental factors for a person falling in the narcissistic spectrum in terms of familiar family relations, attachment, early childhood experience.
No, I didn't understand your question.
Oh, okay. I was wondering if what are the common developmental factors?
Oh, I see. The etiological factors.
Yes.
We have only partial knowledge of this clinical one. Our epidemiological knowledge of etiological factors is still very thin in that area, in contrast to borderline personality disorder in a strict sense that I mentioned yesterday. I don't know whether in what we find clinically, and I think most people would agree on this, is generally great frustration in the need to be really honestly loved. And very often we find, on the one hand, ungiving, indifferent mothers, and a replacement of love by admiration. The child is used for as an object of admiration. I'm coming here with that. And so to be admired replaces the wish to be loved. On the other hand, there's also lack of displacement of that from mother to father. So you may have a very weak, powerful mother who is very aggressive and a very weak father, especially for male patients. This becomes a major problem, but also for both, with different dynamics. So severe frustration or an unconscious hostility from one parental object and absence of compensating one from the other. And something that, a kind of a major capacity that then becomes a nucleus for feeling one can be admired, one is superior, and the sense that replaces love. And very often in unconscious teasing going with that. Seductive mothers who are really cold. So the seductiveness evokes the desire, erotic and dependent, and then it's frustrated, and that generates intense envy. Envy is a primitive form of aggression, which is different from hatred, from ordinary hatred. In hatred, you have an enemy whom you want to destroy. That's kind of neat and easy. In envy, you hate somebody who has something that you wish for yourself. Envy implies, by definition, recognizing something good there that is being teased, or that's teasing, and a wish to destroy it, to eliminate the rage that that good thing is being withheld from you. So it already recognizes something good, but that's being presented and withheld, a kind of a contradiction. So these are complex interactions, much more subtle ones than simply battering, aggressive, unavailable parents. But that's a very general statement, and I don't know whether we can go beyond that at this point.
You talked about a couple of things that patients do that you say defend against their acknowledgement of aggression, like excessive curiosity about the therapist and the pseudo-stupidity and those sorts of things.
The syndrome of arrogance, that was described by Bion. We see that typically in some patients. It's extremely interesting because it's so frightening and threatening to the therapist, but once you have an understanding, you can handle it, namely that it implies incapacity to acknowledge that it's being acted out rather than being acknowledged. If you help the patient to acknowledge it, the acting out decreases.
Well, I wanted to ask about if sexual feelings in patients for the therapist kind of tie in there at all, and
sexual
so how would you interpret that?
Very good question. Yes, there is a particular pathology of sexual involvement or sexual feelings toward the therapist that's typical for narcissistic patients. About this we have a lot of experience. In fact, I just realized I didn't mention that. I have to put this into this presentation. Let me summarize it briefly. Patients with neurotic personality organization, non-narcissistic patients who are in analysis with a higher level, tend to develop erotic feelings as part of the transference. The typical example, the classical erotic transferences of women in treatment with men, that was first described in psychoanalysis. Created lots of problems for the early psychoanalytic movement and all kind of murky business there. So women with a neurotic structure tend to develop erotic transference to the male therapist. Women with a narcissistic personality structure don't, because to become erotically involved means to depend. So these are remarkably non-erotic transferences. And they only evolve after resolution of the pathological grandiose self in the advanced stages of treatment. Exception. Well, it gets more complicated. When there are severe antisocial tendencies in women with syndrome of malignant narcissism, overt borderline features, there may be efforts to seduce the therapist to get him down as a way to destroying him. Now,
Male patients?
I beg your pardon?
Can you say a little bit?
Yeah, now I'm going to talk about male patients. Male patients, so you see how it's interesting but complicated. I think what I said can be pretty much generalized and helps for male therapists or analysts understand why there are no erotic transferences with a certain kind. Of course, by the time you have some experience, I mean, that becomes pretty obvious. Contrary case, a male narcissistic patient with female therapist. Male patients with neurotic structure. Generally, the erotic transferences toward a woman analyst is present, but less intense than the case of women with men, and more displaced toward other women. Why? Because a woman falling in love with a man fits the social gradient of power, particularly in a patriarchal society. So it's a socially tolerated and acceptable dependence, the little girl on Big Daddy. While the little boy being interested in mother is a threatening situation. It runs on the one hand against the social gradient, a man dependent on a woman, and it touches deep Oedipal fears, quoting here Chassé-Mirigel's very important work on narcissistic issues in men. The little boy senses that his little penis is not enough for mother's big vagina, I mean, to put it in the most primitive genital terms. So the tremendous sense of fear, inferiority, and insecurity toward the female analyst leads to displacement. So and that needs to be interpreted in the transference, of course. Now, males with narcissistic personality, there you have a typical problem, an effort to be seductive toward the female analyst, to get her down from her high level and reconstruct the social gradients of the superior male seducing a female therapist, so that the erotic transferences there are narcissistic and not Oedipal. And that shows in the countertransference, because intuitively the female therapist or analyst senses that erotic attraction has an element of attraction, or an element of aggression, although it may also be very attractive, seductive and aggressive at the same time. So it's the inexperienced woman therapist may find this quite frightening. So that needs to be analyzed. And of course, if it's a syndrome of malignant narcissism, even more so, with an effort to destroy the therapist. Let me stop there, because you can also apply this to what happens to homosexual patients, where again the dynamics change. But I think what I said already gives you the general frame, and that's quite helpful to keep that in mind. So, a very good, important question.